Good evening, everybody. Thank you for coming to this SHA meeting this evening. What we're going to do, we're going to hear from each of our speakers. And we've got Belle, Ribeiro-Addy, we've got Helen, Neary, we've got Rowland, and we've got Puntis. They're all going to speak to us tonight. And then after the contributions from our speakers, we'll invite contributions and questions from the floor. And we invite the panel to respond. And at the end, we'll ask each of our panel members to just sum up their takeaways from this meeting for you. So by way of introduction, you might have been at our meeting last year, where the SHA talked about its report in place of profit. And we talked about the revolving door whereby corporate executives shuffled in and out of the NHS, instilling the corporate view that is now commonplace in the NHS. And our view is that the revolving door is accelerating with the NHS 10-year plan. This is following a 4 decades long onslaught on the NHS public service. So we can see, for example, in the 10-year plan, that certain revolvers, as we call them, are in the forefront of the plan. So specifically, Revolver 1, Michael McDonnell of United Health and the World Economic Forum, is prominent in the NHS now and now has a seat as a non-executive director on the Department of Health and Social Care. And sorry, this is Alan Milburn is back on the Department of Health and Social Care. And Alan was the new Labour Secretary of State for Health from 1999 to 2003, and he promoted NHS outsourcing, including by buying NHS operations from private hospitals and PFI outsourcing. He's had a lucrative post-political career with corporate consultancies, including firms profiting from the fact that he's reformed the NHS, and he's also a member of the World Economic Forum. So our view of the 10-year plan is that it firstly places huge reliance on untested digital technologies to replace potentially skilled staff. It promotes further reliance on the private sector for care, and it promotes further reliance on the private sector funding, indicated in the government infrastructure plan and echoed in the NHS 10-year plan, returning us to public-private partnerships and PFI. As for PPP and PFI, this is a terrible plan. PFI was stopped by the Tories following condemnation of the approach by the National Audit Office in 2016. Now Labour wants to bring it back, apparently because of the self-imposed investment rules to reduce public sector net financial liabilities, and even though public sector fixed asset creation is only actually 1% of GDP. So specific areas for PPP in the plan are elective care facilities with greater reliance on the private sector for less complex care, and neighbourhood health centres. And there's a neighbourhood health centre project called Project Wings, which is going out for expressions of interest from the private sector, the spending of 1.2 billion, which will mean that facilities are running as public-private partnerships for 30 years from June 2027. So tying us in to 30 years of commitment to private sector funding. Needless to say, we want to call this approach out. So we say, as the SHA, we want to reverse the marketisation and corporate grab of the NHS and call for the restoration of the NHS as a publicly funded and provided NHS operating in the context of fully functioning welfare state. And we believe this to be the essential responsibility of the government, in our case, the Labour government. I'm really pleased to welcome all of our speakers today to give their perspective on the NHS now and possibly the 10-year plan. First of all, I'm delighted to introduce Belle Ribeiro-Addy. Belle is a British Ghanaian Labour MP who entered Parliament fairly recently in 2019 and currently represents Clapham and Brixton Hill. Bell founded and currently serves as chair of the all-party parliamentary group on Black maternal health, where she champions efforts to tackle racial disparities in maternal care. Before becoming an MP, she worked as Chief of Staff for Diane Abbott MP, trained as a lawyer, and was a student activist campaigning against the British National Party and serving as the National Black Students Officer, the NUS. Thank you very much, Belle. Over to you.
Thank you. I think you forgot to mention that I'm a proud member of the SHA. That's wonderful.
Thank you.
Which is about the most important thing in this particular meeting. And you know, and as a member, I really want to thank the SHA for their support in the beginning for my deputy leadership campaign. Obviously, I know you've now nominated a candidate, which is right, but I have noted your objections for an exclusion of a socialist candidate on the ballot. And as I said, I'm really proud to be a member of the SHA because you understand how important it is that we have these broad range of views across our Labour Party and continue to champion socialist views in our health service, which I think is so important, especially given the challenges we have today. Now, I know you've heard firstly about how much I'm involved in aspects of Black women's health. In chairing the all-party parliamentary group for Black maternal health, and I've been highlighting and campaigning these issues because actually Black maternal health outcomes are shockingly poor. Now, just 1 week ago, the Health and Social Care Parliamentary Committee issued a report on Black maternal health, and they found that Black women in England face disproportionately poor outcomes in maternity care, and that these are shaped by systemic failings in leadership, training, and data collection and accountability. Now, time and time again, the committee's inquiry heard from clinical experts and women themselves that racism is at the core and is one of the drivers for poor maternal outcomes for Black women, and about cases where racist assumptions have directly harmed Black women's care. As it stands, Black women are 2.3 times more likely to die in pregnancy and childbirth or the postnatal period. And this is a shocking catalogue of failure in a two-tier health system. And it's important that there can be this focus on Black maternal health because every advance in the treatment of Black women, I believe, will benefit women as a whole. And that's because Black women are clearly at the bottom of the pile when it comes to maternal health, and all women would benefit from the improvements that will be needed to reach these women at the bottom of the pile and who are often the last to be considered. And actually, because even though over a period of years, the outcomes have changed, there was a time when it was actually 5 times more some years back, and it's now 2.3 times more. What has been found by researchers is it's not because Black women's outcomes are getting better, it's because all women's outcomes are getting worse. And that's a terrible thing for a country such as ours. Now, that same report also notes that the NHS in England has paid 27.4 billion in maternity negligence claims since 2019. This is estimated at a figure greater than the total maternity budget for the same period. And investing in decent maternal health care would actually be a saving for the NHS, not to mention what is happening to these families overall. But these same terrible failings and shocking statistics can be found in all aspects of healthcare on Black mental health, women and men, on geriatric care, on paediatric care, and so on. And another recent report shows much worse outcomes for Black men in the treatment of prostate cancer, and it goes on. And in each case, these failings are the same, the remedies are the same, and the outcomes would be comparably beneficial to all. The remedies include proper funding. Over time, the real resources of the NHS need to grow by about 4% a year in real terms. And this is because the population grows and ages and conditions become more numerous and complicated for ageing patients. And there's also specific inflation for medical equipment and treatments. This is quite natural, even though successive governments have tried to fight against it. This is shown in all the data across countries and over time. And as prosperity rises, economies spend more on healthcare and education. It's almost a law of economic development. And as we become better off, some people want to drive a fancier car or wear more expensive clothes, but most of us want our loved ones to have better healthcare and even more. The NHS as a universal public body is ideally placed to achieve that. When it fails in its mission, we have key indicators that tell us exactly what's happening, and they are called waiting lists. But again, successive governments have tried to fight against these inescapable and objective trends, but their chosen method is to increase the role of the private sector through PFIs and PPPs, through piecemeal privatisations to outsourcing and to sweetheart deals with the private sector, and it's all completely self-defeating in the end. So when commentators and ministers talk about the unsustainable level of the NHS, the lie is twofold. Firstly, health spending is supposed to rise in a civilised society, and I hope that we stay civilised. We do not need to eat more or drink more or live in mansions, but we do need better healthcare. And the second part of that lie is that more of what is being allocated as public funds allocated to the NHS ends up in the pockets of private providers. In the most recent years, the NHS funds allocated to private providers almost about 12 billion a year. The NHS spends billions each year on servicing PFI and PPP contracts, and all of these are often licensed robbery. There is also no proper accounting for the potential profitable bits of the NHS which are being privatised. The result for all of us is the worst of both worlds. We have rising costs in the NHS, and health expenditure has risen, and as a proportion of a very weak GDP, and just worse outcomes overall. We are spending more but getting less for our care and for our money, because of a growing proportion of that expenditure labelled NHS is actually going to the private sector. So historically, this country has had great paediatric care and terrible dental outcomes. That's because you don't have to pay for paediatric care. People in this room will know that in the USA, a country in the OECD which spends by far the most on healthcare, USA life expectancy is one of the worst of all of the advanced industrialized countries, on par with Latin America and Central and Eastern Europe. The USA now has a life expectancy below that of Cuba. And why, you might ask? Well, someone has got to pay for all of those enormous profits of the overwhelming private healthcare system in the US. And this is the model of successive governments have chosen to follow there, including this one. And I'm sorry to say, we now have the spectacle of US healthcare giants openly trying to bully the NHS into buying drugs at inflated prices. And some of them are actually just taking over our GP surgeries, for example. I know my own GP surgery was taken over by a US healthcare giant, and they didn't even tell the people that work there, and they didn't even tell us, the patients. Now, Big Pharma has no pipeline for game-changing mass market drugs that can yield them billions, and their answer is actually to arm twist the NHS, that is British taxpayers, into paying much more for exactly the same drugs. And I'm not certain that I have faith in our ministers to resist them at the moment, not least when we see how eagerly we have accepted Trump's tariffs and the British media held it as a triumph. Now, I wanted to conclude with this, that the NHS remains the most cherished institution in Britain, and it remains this way for a reason. The population wants to preserve and develop it, and at the same time, we see private healthcare across the world looking at the NHS as one of the biggest single prizes that they can go after, and we have to stop them. If we don't stop them, I fear for something which is quite possibly one of the best things to ever come out of this country.
Thank you, Belle. Yeah, the sector of the NHS being a £200 billion prize, the corporate sector, and the fact that what people want is better healthcare. Absolutely, PFI, it's a lie. Thank you very much. Next, I'd like to introduce to you Dr. John Puntis. And John is chair of Lee's Keep Our NHS Public, which he set up in 2011. Is a retired paediatrician who specialised in gastroenterology and nutrition at the General Infirmary in Leeds. John worked as an NHS doctor for 40 years. He's a member of Doctors for the NHS and Doctors in Unite. He joined the executive committee of Keep Our NHS Public as secretary in June 2017 and became co-chair in July 2019. and actually recommend the comprehensive privatisation briefing recently published by KONP. And there's also this booklet here, which I think you can see at the back, which is about subcodes. Now, I've heard today that West Streeting had said to people that he's managed to get subcodes off the agenda, even though we actually know that it was HMRC that told him that they couldn't keep the VAT. So delighted to welcome you, John.
Thanks very much, Esther, and to the SHA team for I think the issue over subcodes is important, but it's illustrative of the fact there's quite a lot of chaos at the top at the moment. So not long ago, you had Jim Mackey, the interim head of NHS England, telling trusts that they had to outsource or they had to set up subcodes for their facilities staff. And you've now got West Streeting saying, don't do it. I'm not quite sure what will happen in practice. These are a few frames from an excellent exhibition about subcodes that's been prepared by Marion McAlpine, who's sitting at the back there, and a fantastic booklet that goes with it. It's possible to borrow the exhibition, and we hope people will do that and share it in your local area. So I'm going to talk a little bit about Labour's promises and what it's saying in the 10-year plan. And these obviously are the kinds of discussions that we're having in Keep Our NHS Public at the moment. So Labour promised to get the NHS back on its feet by cutting waiting times, creating extra appointments and returning to NHS performance standards. Now this was a big promise to make, and it's supposed to happen within this Parliament. But I think significantly, if you look at the manifesto and you listen to the promises that were made, although there were commitments to public funding and care being free at the point of need, there wasn't any commitment to services being publicly delivered, and I think that was very significant. And the argument is that if the NHS pays a private provider and you go along and you don't have to put your hand in your pocket to get money out or write a check, then it's still NHS. Whereas we would say, that's privatisation, because some of that money is going out of the NHS to shareholders, these companies legally obliged to make profit. And actually, if you let the market in like that, it distorts clinical priorities. And I know David will say something about that. And in fact, very quickly, 2.5 billion investment was announced in the private sector to help bring down waiting lists. And this was justified in the sense of private companies being willing partners in the endeavour to look after our health. And I don't think that's a sensible way of seeing it. I don't think it's a way that industry would see it. For example, you would never find businesses giving their core services out to their major competitor. And yet that's exactly what the NHS is doing. Interestingly, we were always told the private sector is lean, mean, efficient, much better than the public sector, which is wasteful and slow. You've got this really efficient private sector. And then suddenly we're told, hang on, it's got lots of spare capacity. It's got empty operating theatres, lots of staff twiddling their thumbs. So it's not actually that lean and efficient. And we have to use that capacity. It would be wrong not to use. Well, of course, there's big questions about that. No mention that the private sector is small compared to the NHS, that it relies on the NHS for training staff. That it relies on the NHS for sorting out the many problems when things go wrong. So almost 7,000, I think 6,600 patients each year transferred back from private hospitals into the NHS to be sorted out. It's got major problems, serious problems with governance and medical issues. And a key thing is that there is only one pool of staff, essentially. So if you've got anaesthetists and surgeons who are going off to do operations in the Spire Hospital down the road, they're not doing them in the NHS hospital where they're based. So the idea is that they add spare extra capacity, I think, is wrong. And Alison's Pollock recently published a good paper on elective orthopaedic surgery, looking at the data from, I think, the last 25 years and saying, look, what happened is that actually overall activity goes down. It doesn't go up when you promote the private sector. The NHS pays them to do work. And it actually increases health inequalities because people who are poor have comorbidities. The private hospitals actually don't take them, they leave them to the NHS and they end up waiting longer. David will talk about cataract surgery, but that's a kind of brilliant example of how outsourcing to the private sector is maybe good in a sense of bringing down waiting lists, but it's much more complex than that. So it actually means that the private sector only takes simple, straightforward patients. They leave all the complex stuff to the NHS, which has got less money because more of the budget's now going on cataracts. Their staff are going over to the private sector. They struggle more to provide the care for people who've got serious eye conditions which are threatening their sight. So you have Ben Burton, the president of the College of Ophthalmologists, say the current situation with relation to ophthalmology and cataract surgery is you have people with very mild cataracts being operated on at the expense of patients going blind. One justification for Labour contracting out services has been, oh, it's only short term, it's just to get the waiting list out. But the integrated care boards have been told the only way you'll attract investment from the private sector is to give them long-term contracts. Long-term, 3 to 5 years, possibly longer than that. And of course, the independent sector is not interested in helping the NHS out as an altruistic measure. And it does want to be locked into long-term contracts to know that its profits are guaranteed. The private finance being mentioned by Esther. This is a really bad idea, something which we only illustrated brilliantly this morning. I'm sorry I wasn't there, but I see it hit the, was publicised in the Daily Mirror. You know, PFI was abandoned. It was a cross-party consensus because it was very, very expensive. And it doesn't matter what you call it, they won't call it PFI, they'll call it something else. They'll say, we've learned the lessons, but at the end of the day, borrowing money from the private sector to do stuff is very expensive, and we shouldn't go back to that. Now, Lord Darcy's report was useful in terms of being an in-depth diagnosis, but it was supposed to be the basis of ministers then prescribing the right treatment. But it seems to me that some of the important things he said have been totally ignored in the 10-year plan. So he said, don't do what Lansley did, sack loads of experienced managers, because the NHS still hasn't recovered from that. And he also said, don't have major reorganisation, because this always creates chaos and there's lots of unintended consequences. Another thing is that in the Francis report on mid-stats, Francis recommended you do not have a major reorganisation like getting rid of NHS England unless you have a wide-ranging public debate and you have a risk assessment. That's been ignored as well. Abolishing NHS England and slashing ICB costs may mean up to 30,000 job losses. But because of the financial restraints on trusts now, 6.6 billion deficit, many trusts are now looking at getting rid of staff. And it's not just admin staff, backroom staff, it's clinical staff as well. So trusts are scaling back services like talking therapies, rehabilitation centres, diabetes care, end-of-life services, virtual wards, mental health services. This is what's happening. Now, how this will improve NHS performance, I just don't know. The whole idea that you cut managers and you cut staff and things get better, I think is crazy. And of course, it's now all stalled because ICBs are saying we don't have the money to fund the redundancy payments, probably about 1.3 billion. And we've already come up with our financial plans, so we can't do anything. So there's a real impasse now. And Jim Mackey said, if the Treasury don't pay up, we'll have to go to Plan B. Does anyone know what Plan B is? I have no idea. I don't think there is a Plan B. But the Treasury have now said, no, we're not going to pay. Often small gains are put forward as evidence that there's a big turnaround and things are improving. 40,000 more appointments. Yes, that's welcome, no question. But that is less than 3% of the normal volume of appointments that the NHS deals with. And it's in the same order of magnitude as the increase that was achieved under the last year of the Sunak government. You probably need to have 7 times this amount of appointments to actually bring down waiting lists and bring them back to where they were. And again, have waiting lists come down? Maybe 200,000, but some of that was because patients were removed from the waiting list. They've now actually gone up a little bit more. And if you look at that trajectory, you're talking 20 years to get back to the waiting list that we had back in 2010. So these are very, very small gains, I think. And then the whole idea of doing something about the acute care pathway seems to have vanished. Royal College of Emergency Medicine says 16,000 people dying every year because they're sick, they're in A&E, they need to go to bed, there's no bed. Why is there no bed? Because 1 in 7 of them have got patients in who are well enough to go home, but there's no community support for them, so they stay in hospital. Now, the Department of Health said, we don't recognise those numbers. That's a pathetic response. The RCA, the college, they used NHS data, they publish in peer-reviewed journals, they show you the methodology. There's no excuse for saying we don't recognise that data. If anything, they should have attempted to refute it in the scientific literature. But of course, a lot of health policy operates in an evidence-free zone. Actually, logically, social care would be top of your agenda if you wanted to improve things in the NHS. Because if you actually had better social and community care, you would get people out of hospital, patients from A&E into beds, patients from ambulances into A&E, and the ambulances would be going out and picking up patients with serious conditions. So Labour, I'm afraid you're going to have to do much better than this. And I just reminded you of a few other promises in the manifesto. One is that there would be the biggest outsourcing, the biggest rollback of outsourcing that we've ever seen. Haven't seen any signs of that as yet. Maybe you could claim that for the subcos, but they're not talking about reversing the subcos that are already out there, like the one in Airedale near where I live, where the workers are on strike at the moment. And what about the commitment to the new hospital building programme? That was in the manifesto, a surprise and a very welcome surprise, but soon as in power, we can't afford it. Now we're talking about another 20 years before those 40 hospitals are delivered. In Leeds, we've had a big, not a building site, but where the buildings have been knocked down, waiting for the new hospitals to be built for 6 years. The trust in Leeds now has a maintenance deficit of 650 million. It would need that money just to bring its facilities up to standard. And it's spending out money on patching up roofs and keeping old, out-of-date buildings going. And it was really depending on being in the first wave of the new hospital programme, and those hopes have just been dashed, and no signs of that coming to fruition for a very long time. Now, I'll take just a few minutes. I'm probably going on too long, but the 10-year plan. The Nuffield Trust described Chapter 8 of the plan as an investment brochure directed at the pharmaceutical and medtech industries. It's not really a plan, is it? I mean, the implementation chapter, which was there in draft form, was left out. It's more a list of, this is what we would look like things to look at in 10 years, but we're not going to tell you how we get there. We'll just cross our fingers and hope, because big tech, AI, genomics, robotics, this will make the big difference, and it'll all be fine. I mean, I don't know who writes these kinds of reports, to be honest. They're not scientists, and they're not experts in health policy or in how health services work. And every doctor pointed out the number of representatives from the private health companies, that were sitting in the working groups that were devising the long-term plan. The Prime Minister says in the introduction that the 29 billion from the spending review will be enough to transform the NHS and fully implement the 10-year plan. Well, 29 billion, that was less than the historical uplift for the NHS. And NHS providers that this won't be enough to cover the increasing cost of new treatments, with staff pay likely to account for a large proportion of it. And the Nuffield Trust basically said it might allow the NHS to stand still, but it's not going to give it what it needs to transform. And I think there's many key assumptions in the 10-year plan which are flawed. One of them is that community care is cheap and it will save lots of money. And people who know about community care, like Thea Stein, who led a community trust for 10 years, writing in the Times, says actually it's quite expensive, good community care. And we've got bad care at the moment, so we need a lot of investment. And it uncovers unmet need. So the idea that suddenly you can switch to community care and you save a lot of money is wrong. I think the other terrible thing in there is all about the faith in artificial intelligence. Now, of course, I completely accept that in radiology, there may be artificial intelligence that can be benefited in terms of diagnosis. But to think that AI is there waiting, take it off the shelf, transforms the health service and saves masses of money. This is hype. This is deliberate hype from those who are investing in AI. There's huge investment in it. And a lot of what's in the 10-year plan evidently comes from the Tony Blair Institute and Larry Ellison, second richest man in the world, who are saying the future is AI. Actually, it's not. And there's people who are writing very good critiques of why this hype is wrong and why it's disruptive. Before the election, the NHS was one of people's top concerns. It still is after cost of living. And Labour said they were going to make things better. They also said that the private sector and the NHS have common aims and objectives. I don't think that is true. The aim of the private sector is to make profit. It also says that what made the NHS better under New Labour, when undoubtedly public satisfaction soared and waiting lists came down, they said it was Alan Milburn's privatisation and patient choice agenda. It was not. You could look at the ONS data. This is set out in the document by the 99% organisation. They look at what actually improved things under New Labour, and there were very evident improvements. And it was investment, because they increased the uplift on the NHS budget by something like 6.8%. Investment in staff and facilities improved things. The other reforms probably had marginal effects, some of them negative effects, some of them maybe positive. But it is completely misrepresenting the situation to say that Alan Milburn was responsible for improving NHS services. And now, unfortunately, he's back right at the heart of the Department of Health. And of course, going back to the same failed policies, use the private sector. Foundation trust, they didn't work last time. There's no evidence that foundation trust status conferred any kind of benefit at all. And Labour just doesn't want to hear this because they don't like that we've got to pay more. What they are saying is that with these technological improvements, that this will save a lot of money. That's highly questionable. It's not evidence-based. And look at one of the key themes in the 10-year plan, genomics. You test everyone's genetic makeup at birth, and then you give them a book saying these are the things you're going to die from or you're at risk from. You know, this is madness. There's 8,000 genetic diseases. You can only treat about 5% of them. Sometimes the treatments are very expensive. You know, would you get them? You make everyone a patient from the moment they get their first test back. Create huge worries. You'll have a lot of false positives, false negatives. You'll have genetic mutations. People will not know what they mean. We already see this. You know, think of antenatal testing that women get privately from the private clinics, and then they get a long list of mutations. No one knows what they mean, but they go to the NHS and say, "What does this mean? What needs to be done?" And we have screening committee in this country which looks at whether there are diseases that you can intervene in, change, whether you have a good test that works, it doesn't have false positives, and actually they look very carefully at the risks and benefits. This doesn't seem to have happened as far as I can see, and this is a massive project, hugely expensive. And I can imagine the private sector coming in and saying, well, we've seen your list of risks, you know, why don't you buy this exercise program? Why don't you follow this diet? We've got supplements that will help you, this kind of thing. I think it's just absolutely mad. And what would be much better, and I'm going to finish now in the next minute, what would be much better is across government to actually attack health inequalities by reducing the social determinants of health, poverty, poor housing, poor environment, poor jobs. We know that those things work and they would improve health and they would reduce this upstream pressure on the NHS in a way that genomic testing, I don't think, is ever going to do. And I think in parallel to the NHS or in tandem to the NHS, we do need to see the National Care Support and Independent Living Service brought through, not just to decrease pressure on the NHS, but because so many people do need social care that are denied it at the present. And it's there, as I say, not just as a handmaid for the NHS, but it's there to improve people's lives. Res Streeting at the BMA conference recently told the docs, you know, if you go on strike, this is an invitation for Reform UK to come in at the next election because the NHS won't get better. Well, he is right. He's right about one thing. Labour's made some very important promises, and if it is not able to deliver, people will undoubtedly look elsewhere, and they will be looking at reform. So they're taking huge political risks if they do not do something that actually makes the NHS better. There's still time to change direction, but it is now a matter of emergence. Thank you.
Thank you, John. Of course, reform will be an absolute disaster. The NHS. Thank you for that really, really comprehensive critique. And I recognise so many facts figures you cited there. Really, really helpful. Thank you. Next, we're going to hear from Dr. Helen Neary. So Helen is co-chair of the BMA UK Consultants Committee and was elected in September 2024. Helen's been a consultant anaesthetist here in Liverpool for over 10 years. She previously worked in Hull and Newcastle, but returned to her home, Liverpool, nearly 20 years ago, having grown up across the water on the Wirral. Thank you, Helen.
Hello, everyone. It's a pleasure to be here. As said, I am the consultant anaesthetist here in Liverpool and co-chair of the BMA committee. And this committee represents consultants across the UK and negotiates on behalf of consultants in England with employers and government. So I want to start by thanking Socialist Health Association for bringing us together today and giving us a platform to talk about the future of the NHS. Today, I want to talk a little about the industrial action that you will have seen from doctors over the last few years, why it's been necessary, as well as the future of the NHS following the recently published, as we're talking about, 10-year plan. Like so many of our public services over the last decade, decade and more, we've had to bear the hard edges of austerity. And it's important to note that while austerity was limiting spend in the NHS, patients' health needs are becoming increasingly complex, and with an ageing society deserving the best care, and also while staff were dealing with the severe impacts of the pandemic. But it's not just an ageing population that we have to deal with. Right now, there are also huge issues with children's access to mental health care and support. Currently, 1 in 5 child and adolescent psychiatry posts remain unfilled. Last year, the average wait for referral after a referral to the CAMS service was 392 days. That is setting up the next generation for a lifetime of preventable failure and misery. But even before the pandemic, waiting lists were at record levels and burnout all too common across the NHS, including the medical workforce. As consultants, We've seen a huge shift since the 2008 financial crisis in terms of pay, with real terms cuts to pay of approximately 30% when measured against inflation. And similarly, resident doctors, who you may previously known as junior doctors, have also suffered similar levels of pay erosion. It seems like successful attempt by successive governments to pay for the mistakes of others by eroding the pay of NHS workers. And like many NHS workers, we have a supposedly independent pay review body, which was previously described by one Conservative MP as basically rigged. At the same time, consultants have seen the space that we set aside for training, education, professional development, and things like auditing our services, all too often treated as optional extras by employers rather than as part of our contract. The NHS cannot improve or increase productivity without the time needed to assess whether services can be made locally. And that's also while medical academics, who are at the forefront of pushing the frontiers of medicine, are facing huge challenges with too few early career academics and many academics near retirement. This short-term thinking has long-term repercussions for both doctors and for patients, especially given the real challenges the health service is facing today. In 2022, the BMA democratically passed policy at our ARM mandating our committees to campaign for full pay restoration. And since then, we've seen some progress. As consultants, we saw steps towards restoring pay, but the reforms secured did not so far bear fruit. And it was this Labour government which reneged on some of those reforms, as we previously agreed. Beyond pay, doctors are facing the haunting spectre of unemployment. Unemployment in a country where millions and millions of patients continue to languish on waiting lists, desperate to see a doctor, in a country where there are fewer GPs today than in 2015, and a country where doctors are taking jobs as Uber drivers to make ends meet. Disastrous workforce planning has led to resident doctors who need training places to further their careers, and in many cases to actually practice as a doctor, face competition ratios for places which are truly staggering. This year, 10,000 doctors applied to become psychiatrists. Less than 500 will get a place. There are 5 doctors applying for every GP post as patients scramble to see a family doctor. The result will be more of what we've seen already, an ever larger cohort of doctors unemployed, stuck, and looking for an exit. Public health has also been utterly decimated, a fact that was clearly on display during the pandemic. Years of restructure from the Lansley reforms, neglect, and funding cuts left us terribly exposed to COVID, but nothing has changed. There is no convincing plan to put public health back at the centre of policy making, giving it an independent voice to speak the truth. Instead, public health remains fragmented and too distant from important decisions about commissioning services for local and diverse populations. In a closed labour market, employers can undervalue their staff very easily by maintaining a shortage of posts. And they can keep wages low because specialist workers have few other options. But unfortunately for the NHS, other countries value their healthcare workers appropriately, and healthcare workers, especially doctors, have very mobile qualifications and have been voting with their feet. So now we have both the need for more doctors and lots of underemployed doctors leaving to find work elsewhere. This has taken a while to build up and may get worse before it gets better. And this brings me on to the government's 10-year plan for NHS. I think we broadly agree with the shifts as it imagines them of moving some care from hospital to community, some increasing digitisation, and adopting a preventative model of healthcare. They're not bad goals to have, but ambition alone is not enough. It's not just about the destination, it's also about how we get there. And the plan itself is not so much a plan as a description of a potential future. Light on detail, heavy on rhetoric. And it's already causing huge anxiety amongst the medical profession who, quite frankly, have not been properly engaged by the government when drawing it up. Central to it are community-based neighbourhood health centres staffed by multidisciplinary teams, which will include doctors and provide one-stop shop delivering care. It sounds great, but what's not clear is how these centres will be staffed when we're in the middle of a workforce crisis, and how will they be funded when all we hear every day is there isn't any more money. Right now in England, there are doctors who could be working to bring down waiting lists and see patients in general practice. However, the reality is that because of central funding restrictions, no NHS organisation has the money to employ them. There are other risks. Shifting money too abruptly from hospital to community hubs is likely to destabilise an already fragile secondary care sector. Structural reforms require investment and they need caution about transition. The government will need to work with doctors and other NHS staff if it wants to deliver the 10-year plan. And we have said many times that there's little hope of pushing through its reforms to the health service while staff are underpaid, undervalued, and unemployed. Demoralised staff cannot be treated like chess pieces and just told to work harder and longer. So in the first instance, getting the plan going means fixing pay, contracts, and underemployment. We're expecting the imminent publication of the new long-term workforce plan. And again, we've warned the government that this plan must be both safe and credible. We've seen no transparency so far. We've been told none of the underlying assumptions, other than this new plan, will revise down the numbers of doctors needed in comparison to previous estimates. As I've said before, with an ageing society with more complex needs, we need to understand as doctors how this can be done safely. And I have to say that we are currently worried. We've recently seen the dangerous substitution of doctors with physician associates, an attempt to water down high-quality medical care for patients while putting other staff in unfair and unsafe positions. At the BMA, we're concerned that policymakers in Whitehall are increasingly looking towards the taskification of medicine as a great idea which they think will save money. The BMA's Medical Academic Staff Committee have called this approach to medicine an illusion that misunderstands why doctors need to train so extensively to safely treat patients. Medicine simply cannot be broken down into its constituent parts. And the 10-year plan doesn't seek to hide this ambition. It talks directly about a profound change in culture where other professions, backed by AI, can liberate doctors to work at the top of their license. Yes, sometimes there may be straightforward diagnosis or treatment, but this is only ever a judgment that can be made retrospectively. One person's cough may be a symptom of a common cold, but for another person, it might indicate something that needs further investigation. And to figure this out, you need the education, training, skills, and experience as a doctor. It is a strange decision to pursue the taskification of medicine, given Wes Streeting commissioned an independent review into exactly this issue by Professor Gillian Lane. Professor Lane concluded that the NHS had spent years employing physician associates to take on medical tasks despite no evidence of safety and while ignoring the concerns of doctors, patients, and coroners. We're grateful the ambiguity caused for patients by their title will be rectified and they will soon be known as physician assistants, because patients who are sometimes quite vulnerable need clarity about who is actually caring for them. Taskification will only lead to the creation of a two-tier NHS, where in some areas patients see fully trained doctors and in others they see doctor substitutes. We are already seeing a pattern where this is more common in less affluent areas, while patients in wealthier areas have greater access to doctors, widening the very health inequalities that the plan supposedly seeks to tackle. So yes, at the BMA, we are very concerned about how pay erosion is draining the morale of staff who are already burnt out. We're concerned about workforce planning, which is leaving doctors and other professionals on the scrap heap, rather than employing them to help fix our broken NHS. We are concerned that the future plans will repeat the mistakes of the past by thinking the slickest AI will solve ever greater patient complexity and a workforce which is at breaking point. So as the BMA, we will do all we can to engage with government over the implementation of its ambitions for the health service. But we will continue to support our members who too frequently are being told to do more with much less. Thank you.
Thank you, Helen. I heard that word taskification before. Is patients being on a production line and doing a kind of tailorist approach to say we need to move on. Really interesting. Thank you very much. Finally, I'd like to introduce you to David Rowland, who's the founding director of the Centre for Health and Public Interest. He's written on subjects ranging from conflicts of interest in healthcare, pandemic preparedness, the private finance initiative and patient safety in private hospitals. The Centre's work regularly features in the national news media, and David regularly appears on broadcast media. Prior to joining the Centre, he was head of policy at three national health regulators. Recent work has included research on the outsourcing of NHS and care that John's referred to. Thanks very much for joining us.
Right, thank you. So first of all, I want to say a massive thank you to have been invited here this evening. The Socialist Health Association is obviously one of those bodies that has been involved in establishing the NHS and has stuck with the NHS and campaigned for it, along with Keep Our NHS Public and others, in order to ensure that we still have it today. I'm going to talk a little bit about the work that we've done on iCare, but I just want to sort of reflect on something that I always think about when I think about the legacy that we've been left by NIBEV and the people who created the NHS, because often we think about that in terms of the free healthcare that we receive. We often think about it in terms of the institutions of the NHS, but there's another dimension to that which I think we perhaps haven't adequately acknowledged, and that is the fact that when you go to see your doctor for healthcare in the UK, you're insulated from the idea of profit. You don't have to worry that the doctor that is providing you with the service is providing you with that service for any other reason than it's in your best interest. As a patient, that is a massive, massive gift. It's not something which exists globally around the world in many countries, and also from the medical profession's perspective as well. Imagine if you're a doctor who works for a big private equity hospital in India, as is something which is happening now, where you don't have decisions about patient care that are available for you to take independently in the interest of patients, because of the fact that the company which is running the hospital is demanding that you focus on particular types of patients, or that you'll set particular types of targets. So I just want to ensure that we don't forget that that is one of the key legacies that we've been provided with in the UK NHS. It isn't just about comprehensive, publicly provided healthcare at the point of need. It is also the fact that we don't have to worry about the exchange of money when it comes to receiving care and we don't have the ethics of healthcare infected by the profit motive. And I think that is a massive legacy that we are at risk of losing, unfortunately. The work that we've been doing very recently, looking at the outsourcing of NHS eye care services to the private sector, is almost certainly the biggest scandal that I've encountered in my 25 years of looking at the interaction between the NHS and the private sector. Over the course of the last 6 years, we have seen a huge shift of activity away from NHS healthcare, eye care departments, and into the services of private companies that are delivering NHS funded cataract care. When we started looking at this, we had to try and understand how that had happened, because it wasn't the fact that there was any plan by NHS England to shift provision out of the NHS into the private sector. It wasn't part of a manifesto commitment. It wasn't even something that ministers had sanctioned. Instead, what had occurred was something which is actually really quite incredible. There were a number of companies who effectively hacked the NHS system. They worked out that if you are able to set up an eye care clinic in one part of the country and require the local NHS to provide you with a contract, that provides you with the ability to set up an eye care clinic right around the UK. So we now have, over the course of a 6-year period, an additional 150 private eye care clinics that the NHS itself didn't go out and procure. It didn't go out to the private sector. It has been the case in other instances where the NHS has used the private sector and say, okay, guys, we need a private hospital to come in to bring down waiting lists. That didn't happen. What happened was that you saw the establishment of all of these eye care clinics around England, and then contracts being used from one part of England to enable the spread and the establishment of this array of providers. In the same way, for example, that we've seen Costa Coffee spring up everywhere, or Greggs spring up everywhere, or Gales spring up everywhere. This was happening with the NHS's eye care provision. What we saw in relation to that massive growth in the private sector was the need that these private companies who'd invested significantly in some of these clinics to actually get patients to come through their doors. So we tried to work out how it was possible that suddenly, not only had you established all of these clinics that the NHS didn't say that it needed, you were suddenly seeing patients going towards all of these clinics. So we examined the relationship between the ophthalmology providers and the high street optometrists, and we found that there was understandably a very close relationship, because people, when they go to see their optician and the optician examines their eyes, it's usually people over the age of 60, they will be assessed for whether or not they might need a cataract, and it's the optometrist, the high street optometrist, who makes a referral for a cataract operation. That very close relationship has, and this is not just us who are saying this, but it's also briefings that were put to ministers, according to the Sunday Times, revealed that there were significant financial incentives there that were being used by private ophthalmology clinics to win referrals for NHS patients. Now, there is a thing in this country called the Bribery Act. We're not suggesting that any of the companies involved have breached the Bribery Act. We don't have any evidence to suggest that, but there are rules in place which are designed to ensure that that type of payment or financial incentives for referrals does not happen. And yet it did. It happened on a very, very large scale. The other thing that we identified in relation to the provision of lots of these cataract services was that the amount that the private sector was charging the NHS for some of these cataract services seemed to be rather high. So over the course of a 5-year period, we saw a 144% increase in the number of complex cataract surgeries which were being delivered. And all of that 144% increase occurred in the private sector. So when we looked at the data on this, if the private sector had been delivering the same rate of complex cataract operations as the NHS over the course of a 2-year period should in effect have paid £29 million less than it did. Now, we're not saying that there is any evidence of healthcare fraud here, but it is certainly the case that the NHS Counter Fraud Authority are looking into this. So in addition to the fact that, as John has pointed out, we have seen significant amounts of income and activity moving out of the NHS and into the private sector, and that this has been done under terms which hasn't been planned by any of the local ICBs, hasn't been driven centrally by NHS England, but has actually been, in a sense, the product of some very sophisticated thinking by private companies to essentially suck money, resources, and in some cases, consultants out of the NHS, that we're now in a situation where you have NHS eye care departments that don't have sufficient consultants to be able to look after kids. That ultimately is the day-to-day reality of this large shift away from the NHS and towards the private sector. But the other dimension to it, which is why I would say the biggest scandal that we've seen, in addition to all of those things, is the amount of money that is leaking out of the NHS as a result of the way in which these companies have established themselves and the profit margins that they've been able to generate from the provision of NHS cataract care. The average profit margin for a company that is delivering NHS cataract care in the private sector is 32%. £1 in every 3 that is paid by the NHS to the private companies in order to deliver an NHS cataract operation doesn't go anywhere near a patient. It leaks out into the pockets of shareholders and investors. In some cases, that's closer to 50%. £169 million in 1 year is the amount that went out in profit to 5 eye care companies. 169 million in 1 year is more than the annual average amount that is extracted in profit from PFI schemes from 100 NHS PFI schemes. So I think it's really important that when we're talking about what's happening in the NHS at the moment, that the 10-year plan, to me, is a little bit like a Tony Blair tribute act. It's exactly the same stuff that was produced by all of those management consultancies, by all of those think tanks back in the early 2000s. It's exactly the same playbook. But the difference is that the nature of capitalism that we have at the moment and the very significant interest that private equity has in encroaching into the NHS territory means that there is a massive dissonance somehow between the way that policymakers are approaching these problems and the way that the private sector are thinking about them. So I'll just hopefully not leave you with too much dismay, but I think when we're trying to focus our energies and trying to think about what's happening in terms of healthcare more globally, these same issues, these same playbooks, these same approaches that I've described here are exactly the same playbooks and approaches that are being used right across healthcare systems the world over. In the US, interestingly, they have started to take action against the types of activities that I've described here, against private equity providers, because they have seen up close the damage that it has done to their healthcare systems. And unfortunately, unlike us, they don't have the naivety around the profit motive that comes as a result of being granted the legacy that Bevan left us. So there we go.
Thank you very much, David. We recognise playbook. Absolutely. So we have a few minutes now to invite questions and contributions from the floor before we ask the panel members to sum up. I've got 1, 2, 3, 4. Over to you, Esther.
Yes, hi. So I'm Addy. I am also on the BMA Consultants Committee with Hilary, and I suppose I just have a bit of a comment. When I read the taskification of healthcare in the 10-year plan, I think I had a bit of a visceral reaction, because healthcare and patients are not tasks. Healthcare is almost about that relational. It's the relationship that you build with the patient is so important. But the corporatization of the NHS means that we do not value it because we cannot measure it. Yeah, it's one of the key determinants of whether a patient will follow their healthcare plan, will be motivated to get, to do things to get them better. Yet we fail to recognise the value that actually healthcare, we are human beings, we're the same as today as we were 2,000 years ago. And we didn't have the technology we do, but actually we healed still. But we healed because of those relationships and those healing relationships.
That's lovely. Thank you very much. Thank you. Over here, the lady with the hairband.
Oh yeah, can I just say thanks to all the speakers for your contributions. I'd like to just pick up on what you've just finished with, because I have glaucoma, and in 2020, just when we shut down for COVID, I'd gone to have a checkup at St Paul's and my pressures had gone up to over 30, and 11 to 21 is normal. I've been on St Paul's for 5 years, and so I had to go in within 2 weeks to have the first operation. The second operation on my other eye should have been 3 months later, but I was put on drops and they were delaying because of COVID, which I understood. In between that time, somebody rang me and said, Teresa, would you like to come in for your pre-op? And I thought it was St Paul's. So I said, is this St Paul's? And the person said, no. I said, who are you? Where did you get my number? So he said, oh, I've been asked to ring up off a list to ask you to come in. I said, but I'm under St Paul's. I wouldn't be coming to you anyway. And it is one of the eye companies that's well known that we have actually reported to the CQC. And he said, oh, I was just given a list to ring you. I said, but you're duping people because they would think it's St Paul's. I said, I know enough to know that you're not St Paul's, and that's the only place where I would have my eye operation. And given that I have glaucoma and not cataracts, that would have been dangerous to operate on somebody with glaucoma, because they take the easy cataract operations. They do operations when the cataracts are not ripe, which is not great. And just to pick on something that John was saying about the PFI, the last tranche was 200 billion for schools and hospitals, and we've got to pay 500 billion back for that, which we're still paying, which is $500 billion. And an example of that was Alder Hey, when they were about to build the new hospital. I went to an event where the CEO was there, and I said to her, how much funds do you have? And I think she said 250, 300 million. I said, have you got to borrow any PFI? She said, yes, 100 million. I said, how much do you have to pay back? She said, 400 million, which is the cost of another hospital. So I said, you would have to transcend galaxies to find an interest rate that high. And she thought in her arrogance she was great, and she said, if you get a mortgage, you have to pay 2-3 times as much. I said, but I'm not responsible for sick and dying children, and because the fat cats are paid first, then the rest is allocated for healthcare, so some children wouldn't get the treatments they need. And every time Wes Streeting opens his mouth, my ears start bleeding. I don't think, well, they do. They do. I don't think people challenge him enough. When he's speaking, it's allowed to pass. And I always remember watching a documentary about private healthcare in America, and it was an oncologist clinic, and they were giving treatment for cancer to people who didn't have cancer. And it was an oncologist who'd taken a job there who thought, there's no tumours on these x-rays. But a nurse had tried to whistle blow, and she was just shut down and poo-pooed. The doctor did go to prison the wife run away. But he was giving chemotherapy in beds because he got more money than in a chair. And I think the thing with private healthcare, they over-medicate, they over-scan, they over-operate, and you can actually
Anything
lose
they
your
can be
life.
paid for,
And
basically.
Nye Bevan's on
Yeah,
permanent
yeah,
rotisserie
yeah.
in his grave.
Thank you very much. Yeah, thank you. Purple top.
Does that mean?
Yeah,
Does that
that's
mean?
you.
My name's Oliver. I'm a kidney doctor in Edinburgh, an SHA member, and I'm also candidate for the Holyrood elections in May next year. So fingers crossed, we will have a Scottish Labour government in starting to unpick 18 years of SNP mismanagement. So we are watching the 10-year plan very carefully as we put our manifesto together. And because we've got it worse in Scotland, we have 1 in 6 Scots on a waiting list at the moment. We have 10 times as many people waiting over a year as you do in England. So we really need to get these waiting times down because people are dying on the waiting list. People want to be back in work, they're in pain unnecessarily because of the waiting list. And it's really easy, and lots of people are making very superficially appealing straw man arguments that, well, there's all this capacity in the private sector, we stop people being in pain, we get them off the way. These people, we need to put the people first, get them out of pain, and if that's the private sector, so be it. Firstly, they're forgetting that it's the same staff who are down there doing a second job to make ends meet. But I think what we need to do is we need to be clearer with people about what commercial medicine actually looks like. Because people have this naive assumption that it is somehow better, it's nicer, it's like flying first class compared to economy, and it's not. I met a guy the other day when I was out knocking doors campaigning who had been in pain from his hip for 2 years. He could not wait any longer. So he took out a crippling loan to go private, got a complication, got shipped to an NHS hospital and looked after by the same surgeon.
Yeah.
On the, so he was in the ITU in a bed that ITU did not have the capacity for, but suddenly had to find when the Spire chucked it, an unnamed hospital in the commercial sector, chucked him out and sent him back to an NHS hospital to pick up the pieces. That is what is happening.
Yeah.
That is what is happening, and people don't realise that. They don't realise quite what the reality. It's not as simple as come in, get your operation, go home again. And there isn't the same level of an anaesthetic cover and everything else in these hospitals for an ITU that would do that. So I think what we need to be doing is we need to be talking about commercial medicine. It's not private, it's commercial medicine. And we need to be really clear with people about what that actually is and looks like. And it's the same people staffing it, but they're cherry picking either easy cases or they're messing up and putting the burden back onto us at greater expense and slowing down clearing those waiting lists. And so that's a message we absolutely have to get through.
Funding for them to fund the liability will eat into their profits.
Yeah.
So we have the
Paying
liability.
still left paying off the loan that they take out.
Absolutely. So there's a gentleman at the back in green, and then there's. Oh, we've got you.
Yeah, I'm going to be slightly.
Yeah.
Well, no. First of all, I totally support the NHS done by NHS staff and the rest of it, but I think we've got to face. I accept what the Doctor was Scotland saying, but we've got to face the fact that actually sometimes what is happening on the ground, it happens in my own personal experience, because my wife's just had her cataracts done by one of the people you've outlined, without she didn't even understand what was really going on. The optician said, "Oh, let's not do it down there," you know. And they did it quickly, and they've done it very well. So let's, I mean, private doesn't equal necessarily.
Did she need it doing?
And I think we've got to be careful about it, sorry.
Did she need it doing?
Yes. Well, according to the optician, she couldn't see because the double mist in her own. And now she doesn't even need to wear glasses, but that's another issue. And then I've got all hearing aids, and using fortunately the NHS is for controlling the audiology in my part of London. I know in a lot of places it's not, it's gone to Specsavers, and but the waiting lists are long. They are long, and it takes time, and you get really good service when you get there, but then they'll say to you, "Thank you, I can't do the other ear now, you've got too much wax in it, I can't really test that for you, you have to make another appointment, that's another year." It's that kind of service. And I think we've got to recognise that reality and why the private sector's jumping up and down with glee, I think, in this issue. And we've really got to turn around a service, the state-run service, and NHS service, which is really hard, I accept, when the private sector keeps nicking people. But we've got to come up with a service that actually works for people. So the
Yeah, of
private
course we
sector's
do.
not needed.
Of course we do.
That's really what we
Yeah.
want to check.
Yeah, thank you.
Mm.
I'll just take two more from over here. Jennifer at the back,
Yeah.
I saw you this morning.
Yeah, so I'm a Labour Party delegate, but I'm also a member of the RMT. And during the most recent BMA disputes, we joined you in solidarity on
You
the
did,
picket.
yeah.
So it was kind of a question of kind of obviously the BMA. I know recently they had a vote on TUC affiliation. Do you kind of think that's going to be kind of again happening in the future? What's kind of the pathway for that? And then kind of with this current dispute that's currently ongoing, how's kind of the feeling of the members on the ground? Are you kind of seeing a difference kind of across kind of England and in the devolved countries as well? Are you kind of seeing a difference, or kind of is it kind of a strong kind of agreement of what the sole aim is across the board kind of thing? If you could just kind of give an overview of the dispute and then TC affiliation.
Any comments?
Certainly. So in terms of the goal of the dispute, and then well, certainly that is what we call a pan-branch of practice goal across the BMA. So consultants, residents, or previously known as junior doctors, staff and associate specialist, staff and specialist grades, which are the sort of other huge group of doctors who work in hospitals, and GPs, and what we call pay restoration, so restoring pay to what it was previously. That is the goal. Different groups of doctors within the BMA are at different stages of both their career, and so have different priorities and strategies as how they'll achieve that. And equally, health is devolved across the 4 nations, and so each branch of practice has its own devolved committee within those nations who do negotiations with their governments, which is why myself being, although UK co-chair, only negotiate with England government, because the Scottish committees in Scotland negotiate with Scottish government. So the overall goal is to restore doctors' pay to what it was prior to the financial crash. And that's why there's varying amounts, but essentially across the board, it's around 30% real terms pay erosion, which is really, really contributing to doctors leaving at all stages of career and really struggling around retention. The question around TUC membership, that decision is taken at our annual representative meeting, which is attended by a number of hundreds across all different branches of practice, because obviously it is something which will impact on the whole union and all different doctors. So that is a vote and a debate that happens at ARM. Whether that view changes in years to come, I don't know, but it is down to the membership of the union to put forward a debate for that, and then to decide democratically whether this is the time to do that.
Thank you, Helen. I'm going to take a question from Kat.
Oh, thank you.
I thought you had your hand up, did you?
Yes, I did.
Yes, you did.
Yes,
yeah.
I did.
And then we'll have to sum up, I'm afraid.
Oh, she had her hand up for a while next to him.
Oh, all right.
It was hiding.
Okay, brilliant speeches, and thank you so much. I'm from We Own It, and I just wanted to say on the PFI campaigning, today we got 27 Labour MPs signed up to say they still believe in Labour's 2024 manifesto, which says that the NHS should be publicly owned and publicly funded. So we're campaigning ahead of the budget at the end of November, where Rachel Reeves will announce whether or not she's using PFI for neighbourhood health centres. So essentially, if anyone has a Labour MP, you can look on our website and ask them to join this group of MPs, because we're trying to build a bit of momentum around it. And the fact that 27 have signed is good, and if we can get more, we can start to put pressure.
Yeah.
We hope. So yeah.
We can collaborate with you on that, because you're the same. This finding, then we go to summing up.
So Margaret Greenwood, I was MP for Wirral West until last year when I stepped down.
Okay.
And I'm a found member of Defend Our NHS, and there's some lovely members here. So the 10-year plan, there's lots of things about it that I'm really worried about. One of the things I think is where streeting doesn't get enough challenge over the shift to community. Because as I think Helen made the point about, you wouldn't do that suddenly, you would do it in a measured way, you would have a risk assessment and so forth. So there's concerns about if you've got your consultants working in the community, whatever that is, they're not near A&E if they're needed for emergencies. That's one thing. What does it mean for the training of staff and students? Because actually hospitals are phenomenal environments of expertise and knowledge. One of my, I know somebody who's a psychiatrist in Merseyside, and we were talking about it. She said, you know, corridor conversations are massively important. That sort of knowledge transfer that you get every single day is very important. If you fragment it all, you're going to lose all of that. I'm also worried from the patient perspective, because it's all very well saying in the community. I was treated for a skin condition in the community. I had to get on 2 buses to Norris Green. Anyone from Liverpool will know what that means. You don't know where you are when you get there. You don't know what you're looking for. It's round the back of, you know, who knows where it was, right? The hospital is a visible entity. You can run bus services to it and all the rest of it. This idea, this fluffy idea in the community. When I was MP for Wirral West, they moved phlebotomy out of the hospital. And then we had 18 months of my inbox being full of people saying, I can't get there, I can't get. The irony being, the hospital is literally across the road from the most deprived estate in the area, but they moved it into the community, to the poshest bit. You know, so that's their version of, you know, these things have terrible outcomes. And really just, I know it's very short of time, I have a question. So one former finance director had said in the 99% group that I attend, which John mentioned before, was he felt the scariest bit of the 10-year plan was the move from national tariffs based on average costs to tariffs based on best clinical practice that maximises productivity and outcomes. And he said that he felt that this would lead to service closures and potentially hospital closures. And I wondered if anybody had any thoughts on. It's a complicated question, but I don't know the answer.
I could speak for ages about that.
Sorry?
I could speak for ages about that, because I was a finance director as well. But I'll see if anyone else from the panel wants to respond. It's rather a long answer.
Defer to you, Esther, you're an expert.
So, I mean, the whole concept of the national tariff, in my view, is a nonsense, because it's based on averages, and an average is nothing. Nobody is at the average. And then you have things like organisations being told that they have to be below the average.
Right, yes,
So it's just absolutely ridiculous. And the concept of best practice, yes. How do you decide what that is? And of course, every hospital's got a different set of overheads, a different position with regard to what it costs to run their hospital. And there's no reason why one hospital shouldn't be more expensive than another, a whole host of reasons. So no, I think it's a really, really bad idea, but I don't think the national tariff is a bad idea. I think actually hospitals should be funded to provide a service to its catchment population. And there needs to be an understanding of how many wards do we need, how many doctors, nurses, ancillary workers do we, and how much does that cost? How much does it cost to run that facility? Ditch a tariff. Do benchmarking, sure, so that you can see how your costs and your inputs compare with others. But the tariff, in my view, is an absolute nonsense. And it's an industry. It's a massive, massive industry. And the best practice tariff that's creating more industry. So I wonder where that idea came from.
And how many managers do we need to staff?
Absolutely.
They don't know how to run the NHS.
The whole national tariff is a huge, huge industry.
Oh, yeah.
Costing an enormous amount within the state.
Politicians are going up to 103,000 just now. What do? I want our nurses, our resident doctors paid back. Thank you very much. We've been on every strike for 9 years.
I'll just say, as I'm here patient, I'm against the BMA continually threatening industrial action, as they were on the radio this morning, over how GP should be accessed. I agree with the BMA position. It's very simple to understand that patients should be able to directly make appointments with doctors online. I don't see why that can't be discussed with the Department of Health in agreement reached. It's not necessary. This 30% claim isn't going to be paid by this government, is it?
Can we get to
Yeah, exactly.
Yeah.
Discuss and negotiate, don't go on strike.
No,
Yeah.
you've got to use the fair
We
strike.
need to move on to closing comments now, but I understand your point of view. So if I could ask each of the panellists to wrap up with any further observations on the discussion in the room and their conclusions from this evening. Helen, you first.
Thank you for inviting me this evening. I think I just want to pick up on the comment about sort of moving care from hospital into community. I think one of the things that we certainly in secondary care would certainly recognise is that where that has been done before, for example, in psychiatry and in mental health, then the cost of providing that care didn't go down. And I think some of the assumption as to why there is the push of hospital to community for much broader types of current secondary care from the politicians is that the view is that it's cheaper to provide it in the community, and I think they think that it's going to be cheaper, but it's not. It's not cheaper, and I think I totally agree with the points about bus services and actually being a central place for people to be, and so I think that needs to be considered and thought of carefully as to what types of services might be appropriate for that and how that happens. And I think there's certainly we will be looking at sort of what that looks like. I think one of the other things that I've taken from this is just how much outsourcing is taking in profit. I think I hadn't quite, I knew it was they were skimming off a lot of profit, which could be otherwise reinvested into the NHS in terms of the infrastructure and services and staff, and they're skimming it off. I think I had not appreciated quite the size of the scale of that, and that is just for ophthalmology, cataract surgery. And I know as an anaesthetist there are varying other sorts of outsourcing and insourcing companies which are operating within the NHS, because still for the patient it's still free at the point of use.
Thank you, Helen.
Yes, thank you, Esther. So I agree with the gentleman at the back that we need an NHS which provides good care for patients. And I wasn't being facetious about whether your wife needed cataract surgery. The reality is that people are going to their opticians and being found to have early cataracts and hadn't noticed any change in their sight, and are then sent for cataract removal. And I think we have to remember that it's only 10 years ago that in these very detailed and comprehensive rankings of health services in the most developed countries that are done by the US Commonwealth Fund, the UK was, came out as #1. So we had a service which in many respects was very good in terms of international comparisons of how healthcare should be delivered, although of course there was always room for improvement. But we shouldn't forget that it's not long ago when we were rated as #1. And I think what I'd say to this government is you were elected on a mandate of change, and the second most important issue for patients or for voters was the NHS. And you really have to do something about improving the NHS. And the way to do that, perhaps, is to look at what New Labour got right. It didn't get everything right, but it did improve health services. How did it do that? It wasn't by privatisation. It wasn't by PFI. It wasn't through foundation trust. It was actually investing in NHS staff and facilities and increasing the amount of money for the NHS. Those are the lessons that should be learned if they now want to improve the NHS, as they say they're committed to. And we now have 2.8 million people who are unfit for work. It's having a negative impact on the economy. So I would also say, look at what the Attlee government did in 1948, when the economy was in a much worse state. We had a much higher debt to GDP ratio. And they didn't say the NHS is a wonderful idea, but we can't afford it till we've grown the economy. They said we'll build a national health service and that will support the growth of the economy. And they should also, I think, remember what Lord Darcy said, which was it's not a question of whether we can afford the NHS. Actually, we can't afford not to.
Yeah, thank you. I mean, really amazing contributions from everybody on the panel, and also, comments from the audience as well. I think just to go back to the kind of the comment about the fact that how the private sector is perceived and the sort of the individual personal experience. I think there's perhaps two things to say there. First of all, you're absolutely right. What we have seen over the course of the time that there has been this almost kind of unplanned outsourcing of cataract care has been a very large increase in the number of cataracts that have been delivered. And that is a benefit to the population. Okay, there's no doubt about that. I think you're right that, John, to say that early stage cataracts perhaps should be prioritised in favour of other cataracts. But the general evidence is that the sooner you can give somebody a cataract surgery, the better it is in terms of their kind of daily life and their daily existence. However, what we've not seen in relation to the delivery of that service has been a planned approach to it. Okay, so I've cited here £169 million leaked out in profit. The companies that have set up the clinics using NHS consultants to deliver the services back to the NHS, those clinics cost around £1 to £1.5 million. Had the NHS itself been allowed to invest in those same types of clinics, using the same type of equipment which these companies are using the NHS staff, it would have been possible for us to have increased substantially the number of cataracts that we would have delivered. There would have been beneficial impacts to mainly older people as a result of that, and it would have been a lot cheaper as well.
Yeah.
So I think there's something about us trying to unpick as much as we can, and it's hugely complex, the false economics that lie behind these shifts, because you cannot waste any of the scarce healthcare resources that we have available to us. You cannot do that because of the fact that demand is growing so significantly, because of the fact that we've got an aging population, we've got an increasingly unhealthy population. You cannot afford to waste £169 million a year, because if you do that, you're never going to be able to meet the goal of being able to provide a comprehensive healthcare system, and also one that meets somebody's individual needs on a daily basis. So I think, absolutely take the point, and I think, we just need to recognise that the driver behind this isn't planned healthcare, it's market-driven healthcare.
Thank you to all of our speakers this evening. Thank you to our audience for coming this evening. Do join the SHA if you haven't already. You've got leaflets on your seats about a further meeting about child health and child poverty tomorrow. So please come to lunch on that. Thank you very much.